Good morning, everybody. My name is Dr. Dolly Dastor. I'm the chair of the Education Committee of the McGill University Research Centre for Studies in Aging, on whose behalf I welcome you to the Brainy Boomer Lecture Series, which we organize weekly. And today we are privileged to bring to you on the Alzheimer Day, September 21st, the second Alzheimer report, which the McGill University Research Centre, together with the Division of Geriatrics, was commissioned to prepare. We are excited that we have authors of the report, plus the 8 contributors of the report with us today. The report, Life After Diagnosis, Navigating Treatment, Care and Support, is a very important subject because even though 75% of people with dementia are not diagnosed, those that are left without any treatment plans or help to navigate the trajectory of this disease. The report was officially released this morning by ADI International. We realize that there are several events going on in Montreal today to recognize this day, and we thank you that you are here with us today. The link to the report which was presented will be at the end of the program on the chat, together with other links. And we have a special treat because the chair of the Alzheimer Disease International Board has sent us a message, Dale Goldhawk. 85% of the 55 million men and women in the world living with dementia are likely not getting any post-diagnosis care. It is unbelievable outrage. Care, treatment, and support for those living with dementia should be a basic human right. But these words ring hollow. When will governments in the world wake up to this urgent healthcare crisis? Signed, Dale Goldhawk, Chairman of the Board, Alzheimer Disease International. So that's a privilege for us to have that. I now have the privilege of introducing to you 2 authors, Dr. Serge Gauthier and Madame Claire Webster, who will lead us into the report. Dr. Gauthier needs no introduction. He's a clinical neurologist specializing in the development of new tools for diagnosis and treatments for people living with Alzheimer's disease. He is the academic co-lead for the Dementia Education Program and Professor Emeritus Neurology and Psychiatry at McGill University. He was a director of the McGill University Research Centre for Studies in Aging from 1986 to 1997, and it took us to great heights. His accomplishment led to him being appointed to the Order of Canada in 2014 and the National Order of Quebec in 2017. The second person to introduce us to the report is Claire Webster, who is a certified dementia care consultant, certified professional consultant on aging, and a conference speaker and educator in the field of caring for individuals with dementia. She's founder and president of Caregiver Crosswalk, a consulting firm that provides education and support services to help individuals navigate the journey of Alzheimer's disease and dementia-related illnesses. Dr. Gauthier and Claire, the floor is yours.
Merci Dolly, and good afternoon to everyone. Bon après-midi à tous. I will review the content of the report and try to highlight that despite its length of 416 pages, there is something in it for everyone. And some sections will be important for all the listeners, I think. So my next 5 or so minutes will include the content, if you don't mind. That's it. So who wrote the report? The staging of dementia was an important issue for us, and I'll explain why. And then the contents of special interest. Thank you. Next one. So the authors, there's 5 of us at McGill and 2 editors at ADI in London. There were 215 invited authors, imagine, with 118 expert essays. So we had to deal with that over 3-4 months, editing the whole thing and grouping it into chapters that made sense. And there was also, in addition, the request of ADI, mostly surveys conducted from carers, persons living with dementia and professional carers, as you see here. So it's a large amount of information that we have to condense into the document that is now public. Next slide, please. The staging is important for us because it's part of good clinical medical practice. If you have a diagnosis, first thing you'll ask is, okay, what stage am I in the disease? What's next? And how can I plan for the next steps? And this is one gap that Claire will talk about. We don't have the person to help us navigate the next steps. But staging is important, and it will become even more so in the near future because we will have a more accurate diagnosis of the cause of dementia. And that may lead to specific treatments for each person based on the age, concomitant diseases, and the biologic profile. So for now, the staging is important for planning the needs of the person at home and eventually in long-term care. Next slide, please. So the other consideration about dementia is that it's an umbrella term that includes many kinds of symptoms. So everybody's familiar with the memory decline with age, but you also look for words, you look for your car, your way around. Eventually, you don't recognize your house or your spouse. There's a decline in functional ability, and this will be discussed further by Isabelle, but there's a progressive decline in your ability to live alone safely. There's also mood changes that could be very early in the course of dementia, even preceding decline in memory, because you have a bit of social withdrawal, you look for words, so you're a bit shy in a group. And then there may be other types of behaviors later in the course of dementia that are very troublesome, like up at night, wandering, etc. For the purpose of this report, we're just going to discuss mild, moderate, severe stages of dementia, but we hint in one of the staging chapters that there are also other stages before dementia, and maybe Pedro will address that at the end of the session. For the purpose of having a more gentle wording for the people reading the report, we use at ADI's advice early, middle, and late stages of dementia as the main terms. And some chapters are all about early stage, or some are about what happens in the middle stage and what happens in the late stage and what can you do about it. Next slide, please. Some illustrations you will find in the report complement to an artist here at McGill. So this is an illustration of light or mild dementia, early dementia, as we call it. The lady can live alone, but she needs help for handling her finances. Next slide, an illustration of moderate stage, where this person may be alone part of the day, but she needs someone to come every day to help selection of clothes, make sure everything is safe in the kitchen, and the house is safe in general. And the next slide, an illustration of advanced stage or late stage, where there's now a gait impairment. The person is at risk of fall, she has difficulty swallowing, she will get an aspiration pneumonia. So there are some illustrations in the report that you will also find in a booklet that the Department of Education on Dementia at McGill has put together and is available in multiple languages, free online. Next, please. Now, special content for clinicians include how to achieve comprehensive post-diagnosis support in primary care. So we use examples, for instance, from the MINT, MITEN program in Ontario, where you have family practice with the support staff helping the physician. The bottom line is the best care will be with support from allied health professionals. You cannot care for someone with dementia alone unless you could reach out to resources all over the place. Symptomatic drugs, we go over the classic available drugs. Disease-modifying drugs, we touch upon what's coming next. And then our favorite chapter, Pedro and I, chapter 19, 12 different kinds of dementia are discussed. What are the special needs of someone with progressive aphasia, someone with progressive supranuclear palsy, someone with Down syndrome, someone with very late dementia over age 90? Is it a different kind of Alzheimer? Yes, it is, and so on. Next slide. For persons living with dementia, there's two chapters of special interest to them. The first one is how do you deal with the diagnosis? How do you react to it? How can you start planning ahead? And another chapter is multi-domain interventions for you that include nutrition, physical exercise, etc. Next slide. For carers, special chapters for them, impact of the diagnosis on you, the carer, and interventions for the carer. Of course, the carers are everywhere in every chapter because they're the key to a successful post-diagnosis care. And next one is decision makers. So we hope that officials and governments and important international bodies like the World Health Organization will take advantage of this report. There's two chapters on global initiatives and models of care, which Saskia will touch upon. And chapter 22 and 24 are something that we feel as a group at McGill is very key to improvement in care, is education. Education in medical school, nursing school, OT school, about dementia. It should be a core component of the curriculum as much as cancer and diabetes care, etc. And next, I think it's conclusion. General public, hello. So if you're just getting old and you want to know about, okay, what's my risk? There's a discussion about genetic risk, if it's something in your family, cultural implications in 13 countries and regions. This was something quite special because we have essays from around the world, including Africa and South America, that talk about what it's like to live with dementia in these countries and how can we help as neighbors of someone with dementia. And the 23 is strategies for prevention. And this is written by top experts in the world. The best we know about prevention is out there, and we can build on that to live longer and more healthy. And next and last is the conclusion for my section. So staging is important for medical practice, but also for future care that will be more personalized and biologic, a bit like what we do now for cancer. A personal care plan should start at the time of diagnosis. For that, we need a continuity in care. It cannot be a family doctor alone, a neurologist alone, a geriatrician alone. We need to involve other health care professionals. And we need to be adaptive. The disease will evolve over time, and then you die of complications of dementia. So every step must be planned for, so it's a little easier on the family and the carers in general. Thank you. And Claire, you take over right away, I think.
Yes, I'm going to have to find another project for Dr. Gauthier because we have been working so hard and closely together for almost a year and a half on these reports. And so it's just been an amazing opportunity. So my talk is really going to focus on really a call to action for enhanced education for all. Next slide, please. And we know that from not only this year's report, but from the 2021 report, that a lack of education about dementia will have a significant impact on the quality of care and safety of the individual, as well as on their carers. Next slide, please. So dementia doesn't discriminate. What we saw from both world reports, it doesn't matter where people live, what color their skin is, what has been loud and clear on a global, from a global scale, is that what is really missing is at the moment of diagnosis is how there's a lack of information that is not given to the persons receiving the diagnosis as well as their care partners, right? It comes out loud and clear. We did this survey twice last year and once again this year, and it's loud and clear. Next slide, please. So where are the gaps? So when we look at, and these are some of the key points, I mean, we could probably have 3 pages of gaps in both categories, but when we look at the key points regarding persons living with dementia and their carers, first and foremost, they do not recognize the early signs and symptoms of dementia. We are still lacking on a global level about having proper public awareness campaigns about dementia like there are for other illnesses, right? So there's also this whole, the importance of seeking a diagnosis to ensure the best quality of life. A lot of people say, why bother getting a diagnosis if there is no cure? But there is such an important aspect of getting the diagnosis so that we know they can prepare for the future from a financial aspect, legal aspect. We saw that with coming back from the surveys that a lot of people, more than half, do not even have an advanced care plan for themselves. So the importance of a diagnosis, people don't know the pathway. How do we get a diagnosis? Which doctor do I go see? Do I go see a GP? Do I see a geriatrician? Do I go see a psychiatrist? There is no clear pathway right now in terms of how do I get the proper diagnosis. Difficulty in terms of managing challenging or responsive behaviors using non-pharmacological approaches. People don't realize all the safety concerns that could happen as the disease evolves. The big question is always, could I go out and leave my loved one at home for a few hours? Can I not? So there's a lot of issues regarding safety, wandering. There's a lack of information about all the positive sides of what could the leisure activities and cognitive stimulation therapies that can enhance their health and well-being, right? In order to give them hope to maintain a good quality of life. Big issue was about knowledge about accessing support services from community organizations and government agencies. That is global, right? And some countries have better plans than others, but like, how do I access support, right? How do I get home care support? How do I go into a residence? That whole education about the healthcare system and community organizations is a big, there's a lack of information there. And then most importantly, with regards to carers, recognizing our own limits when it comes to being able to cope with the overwhelming feelings of recognizing that I'm tired or that I'm angry or that I'm grieving or that managing those feelings of guilt. A lot of carers feel that I'm all alone on this journey. Next slide, please. So then some of the gaps that we recognize in education for clinicians and healthcare professionals. Assessment and diagnosis. Not all the family doctors are capable of performing an assessment or diagnosis or even recognizing the early signs and symptoms. So not all healthcare professionals have been properly trained in this area. Communication skills in terms of relaying the diagnosis in language that people understand. This came out loud and clear in a lot of the testimonials by persons living with dementia and their carers, is that people want to be spoken to in language that they understand, not medical terminology, but language that they can understand. Also with regards to empathy and compassion in relaying a diagnosis. How is a diagnosis made? How is it told to the person? We want to ensure that you don't have a catastrophic reaction, right? So where is the compassion? Non-pharmacological approaches in terms of managing challenging behaviors, that is a big gap as well. Assessing the ability and knowledge of the carers. So there was a very interesting chapter written about how oftentimes occupational and physical therapists go to homes to assess, to assess the activities of daily living of the person who's living with dementia, but who is assessing the ability of the carer to be able to take the best care possible of that person, right? So there's not enough assessment being done on the carer themselves. And then once again, also from the medical community, their own knowledge about community organizations and government agencies that could best provide support to the person living with dementia and their carers. Next slide, please. So the big call to action right now is we constantly talk about the governments need to do more, the public and private healthcare agencies need to do more, Alzheimer's associations around the world need to do more. But the biggest impact will happen when medical students and allied healthcare professionals of the future are provided with a comprehensive education in post-diagnostic management, beginning at the university or college or training center level, right? It has to begin in the classroom. Next slide, please. So finally, the call to action really this morning was about a call to action to academic institutions around the world to please develop, enhance, and improve your curriculum of dementia care education. Invite persons living with dementia and their carers to share their journey with the students and think outside the box. Do what we are doing at the McGill Dementia Education Program. Offer community outreach programs to the community, to carers, and also these type of programs can provide internship opportunities for medical students. Thank you.
Dr. Jelena is an associate professor and graduate program director at the School of Physical and Occupational Therapy, McGill University, and a researcher at the Center for Interdisciplinary Research in Rehabilitation in Montreal. Her research interests include the measurement of functional abilities in persons with cognitive deficits such as dementia. She developed the Disability Assessment for Dementia Scale, popularly known as DAD, a measurement of functional abilities and activities of daily living, which is used clinically and in clinical trials internationally. Today, she will talk to us on a functional perspective on staging dementia. Isabel, the floor is yours.
Thank you, Dr. Dastor. It's a pleasure to be here with you to celebrate the World Alzheimer's Day. So as Dr. Dastor mentioned, my presentation will be about staging dementia. And oftentimes when we talk about staging dementia, it's in terms of the person's cognitive abilities, for example, their ability to remember things, to be oriented in their environment, or to organize themselves to do a task. So I would like to take these few minutes to present a more functional perspective on staging dementia, and also to discuss the usefulness of considering such an approach. Right. So the functional changes in the performance of daily activities over the Alzheimer's disease continuum usually appear subtly and decline slowly over several years. Evidence suggests that the change that we observe in these daily activity occur in a characteristic hierarchical pattern. So usually we observe decline from more complex activities such as work, demanding hobbies, instrumental activities of daily living that are all important activities to be independently living in the community and engage in daily activities. And these usually will be changing in the early stages of the disease. And then this will be followed by changes in later stage in more basic self-care activities such as dressing, bathing, or feeding oneself. These functional changes are considered clinical milestones for the progression of Alzheimer's disease, and they are usually included in global assessment tools that are used for staging the severity of dementia based on clinical symptoms. And they are important because they impact on the quality of life of the person living with Alzheimer's disease and their families. So these functional changes are strongly related to the cognitive declines, and more particularly to executive functions. So these are the ability to initiate a task, to plan our activities, to complete the task in an effective, efficient manner. And they're also influenced by the behaviors, the motivation, the social and the physical environmental factors, as well as other comorbidities. So if we look a little bit more specifically into some of these stages of functional changes, it was initially assumed that these changes occur after the appearance of cognitive symptoms. However, more recent evidence seems to suggest that we do see some changes early on in more complex activities of daily living, even prior to the appearance of clinical symptoms. So subtle changes in the performance of daily activities may be observed in mild cognitive impairments, where the person will still be independent in performing the activities of daily living, but may experience some difficulties in more complex activities. So it could be, for example, making errors during meal preparation, choosing wrong ingredients, for example. So these can be noted in, again, more complex activities such as meal preparation, financial transaction, using technology, for example. In the early stages of Alzheimer's disease, usually the more complex activities of daily living may start to be more difficult to perform. Again, these work instrumental activities of daily living And the person may need some sporadic assistance to complete these activities. For example, the person may still be able to drive a motor vehicle, but will need to be monitored to ensure that if there's any changes that they are detected in terms of fitness to drive. The impact of the disease is more important in the middle stage of Alzheimer's disease. At this point in time, the person usually is no longer able to drive. Mobility around the home may become compromised as the person may experience disorientation in terms of finding their ways around their home. There may be also more risk associated with the decline, as the person may not be as aware of dangerous situation and then how to react to these situations. And the basic self-care activity also start to become more difficult to do. And the person will need more assistance to be independent and to be able, and the ability to stay safely at home also becomes more compromised at this stage. In the late stage of the disease, the person is experiencing losses in the ability to dress, to bathe, to toilet and feed, and will be completely dependent for all activities of daily living. So the monitoring of the trajectory of decline in the ability to perform these functional activities is important and useful for from a clinical perspective, and this for many reasons. They provide concrete and meaningful information to the person living with Alzheimer's disease and also their family on the progression, because these really impact directly on their daily life and they're very concrete in terms of what happens in their life. The identification of day-to-day difficulty as well as preservabilities, it's important not to forget those preservabilities, can facilitate the implementation of tailored intervention to support the client and their families in their daily challenges. And the person's ability to remain active and engaged for as long as possible in their activities can be facilitated. Also, the knowledge about the disease progression will affect affects a person's daily life can help families better prepare for what is to come and in their decision making with regards to either financial or legal arrangement, or also for the need for placement in long-term care institution. And this may help reduce the stress and burden on the families. Also considering that impairments in functional abilities is related to higher care costs, knowing about the progression of functional decline may assist managers and decision makers in planning the human, the physical and financial resources that are needed to better support the person living with dementia and their caregivers in their home. So in conclusion, I just want to reemphasize the importance of monitoring the trajectory of functional decline to offer better services to the person living with dementia and their caretaker, and also the importance of including assessment of function early on in the disease process to assist with diagnostic and care planning. So I would like to thank you for your attention.
Thank you very much, Dr. Jelena, for elucidating to us very clearly the different stages at what happens to the person and how we have to deal with it. So we look forward to more of it whilst reading the report. Now we have Dr. Maya Geddes, who obtained her MD at the University of British Columbia before completing a residency in adult neurology at McGill University. She completed a CIHR postdoctoral research fellowship at MIT and a clinical fellowship in behavioral neurology and neuropsychiatry at the Center for Brain Mind Medicine at Harvard Medical School, and then joined the faculty in 2017. Dr. Geddes returned to McGill in August 2019. And at McGill, she directs a lab at the Montreal Neurological Institute and is an active member of the McGill Center for Studies in Aging. The focus of her research is to understand motivation in the aging brain and is supported by NIH, FRSQ, Sydney Bio Foundation, NSERC, and HBHL. Today, she will talk to us on her contribution to the report, Behavioral Interventions to Enhance Empathy in Alzheimer's Disease Care. Dr. Geddes, the floor is yours.
Thank you very much, Dr. Dastor, and thank you everyone for being here today. I just want to say that I'm delighted to be part of this report. I'm going to just send this as a, okay. So the subject of the talk today is on behavioral interventions to enhance empathy in Alzheimer's disease care. I'm a neurologist scientist and delighted to participate in the report. I just want to mention that I don't have any disclosures. So let's start by defining what is empathy. We know that this is a complex behavioral phenotype and interaction, and we know that it's important because it influences clinical outcomes. So when we think about empathy, we're actually thinking and feeling about feelings. So this is broken down into two different components. One is cognitive empathy, which is understanding how someone else might feel. And the other component is affective empathy, which is feeling how someone might feel. And you can further break it down into two different parts for cognitive empathy. So there's perspective taking, which is the ability to really put yourself in someone else's shoes in order to understand their feelings. And there's also affective theory of mind. So your ability to detect and understand someone else's feelings and understand that their perspective is different from yours. There's also, in terms of affective empathy, empathic concern, which is that feeling of compassion in response to someone else's pain or suffering. And it's really important to understand the dynamic between the two, because when we have interventions, we need both of these components, but effective empathy can lead to feelings of distress. And so you need to really have cognitive empathy as well in order to mitigate those feelings and to avoid the feeling of distress and sort of build skills around them. Okay. So the reason we really want to focus on empathic care comes back to this idea of person-centered care. So in 2018, the Alzheimer's Association for Dementia Care Practice sort of put an emphasis on the importance of person-centered care. And this is really identity-affirming care, and it's fostered through interpersonal relationships. I mentioned that empathic care is critical not only to person-centered care, but it also impacts health outcomes and how persons living with dementia and their caregivers do in the long term. So it can lead to increased satisfaction, trust of both their caregivers and also their clinical team. It reduces the risk of burnout and burden on caregivers and clinicians. It actually improves our ability to make the correct diagnosis, and it helps with treatment adherence. So when we think of designing interventions that target empathy, this can really be done at multiple levels. It can be done at the level of the clinician, the clinical trainee, and that's really the focus of today's talk and the report. But it can also be done at the level of the caregiver, the person with Alzheimer's disease themselves. And there's some exciting initiatives which actually target community level engagement. And all of these hold promise in improving the well-being of persons with dementia. So when we think about the person themselves, we know that Alzheimer's disease leaves affective empathy intact and reduces cognitive empathy. So reminiscence theory and therapy and different emotion recognition rehabilitation programs have shown some promise in boosting theory of mind, affective theory of mind, and caregiver psychoeducation programs and perspective taking, where caregivers reflect on their role and the impact that the diagnosis or the disease has had on the life of the care recipient, have also shown some promise. One exciting avenue for building empathic care at the level of the clinical trainee and health professional is narrative medicine. So to have an identity is to know who one is in cognition and in feeling. It means having a sense of continuity with the past and hence a narrative, a story to present to others. And in the process of this disease, sometimes our stories need to be held by others. It creates this identity penumbra. So narrative medicine really tries to focus on the singular, the story of the individual. Here's a beautiful example of a patient telling their own story, the diving bell and the butterfly, and the importance of a narrative and giving us sort of a window into the experience. So it's giving truth to individual experience and allowing us to derive meaning and empathic understanding from patients' stories of illness. And narrative medicine focuses on narrative competence, which means the skill to recognize, absorb, interpret, and be moved by the stories one hears and reads. So clinical trainees and clinicians focus on narrative form. So how does a patient tell the story, both in temporality, how's time, content, language, structure, allusion, metaphor, imagery, and this idea of close reading. So really thinking about gestures, expressions, and tones. And by listening to patients' impressions, hopes, and ideas about their illness experience and applying our imagination, memory, and interpretation helps to derive a deeper connection between the caregiver or clinician and the patient, and understand how their narrative relates to our own. So this increases empathy, establishes a stronger therapeutic alliance, and provides more effective care. And when we really think of the ultimate goal of these kinds of intervention, it's to restore to medicine some of its passion, its meaning, and its joy. And this is really the work of Rita Sharon, who pioneered this area. So unfortunately, empathy can decline throughout training. And so there's growing evidence that introducing narrative medicine interventions enhance trainee empathy. These are life history interventions or having students and trainees incorporate elements of patient narratives into the medical chart and files. There's also evidence that empathic communication training that focuses on positively framing statements, direct eye contact with the person living with the illness, avoiding elder speak, active listening, group storytelling, avoiding assumptions, listening to preferences and desires can help improve healthcare outcomes, including reducing agitation and depression in people who are living with the disorder. There's also some virtual reality interventions, which are trying to build on cognitive empathy and perspective taking, such as My Shoes. And it's been shown that this enhances empathy in trainees, particularly those that start off with the lowest levels of empathy. One of the exciting intergenerational community initiatives is exemplified by the Cleveland Regional Story Bank. We're also hoping to introduce at the MCSA, where I have the privilege of working, an artist in residence as a goal. So the Cleveland Regional Story Bank is a multidisciplinary initiative that is at the nexus of health science, humanities, social sciences, and ethics. And it borrows from this idea of big data and moves it towards big social science. So this actually began where persons with dementia shared their stories at their assisted living facility and read them to children at an intergenerational school in Cleveland. And the goal of this initiative is really to compile, store, and analyze individual stories in order to cultivate empathy and help our understanding of the illness experience and the concept of purpose in persons with dementia. So there's still a lot of work to do in this area. The area of empathic interventions in persons living with dementia is in its infancy. We know that there's a limitation because there's often small sample sizes. There's sometimes lacking control groups, so the research rigor can be improved. There's also a lack of consistency of how we measure empathy across these different studies, so building our tools to measure. One of the recommendations we made is trying to implement cognitive neuroscience frameworks, including the NIH Science and Behavior Change, to boost and to sort of focus on empathic processes. We also need to understand how our shift towards virtual assessment and care is impacting empathic care and person-centered care in individuals living with the disease and in caregivers. Even though there's a lot of work to be done, we think we're at the stage where we can recommend that clinical curricula adopt practices to enhance empathy in trainees, including opportunities like narrative medicine. So current evidence supports the implementation of transdisciplinary programs that promote creative exchange between people living with dementia, their care teams, and society. So thank you very much for the opportunity to speak today. I want to highlight a big thank you to Caitlin Walker and Adrian Noriega de la Quilina, who are co-authors and a PhD and postdoctoral fellow in my lab, respectively. I want to thank everyone involved in the report and my colleagues and friends at the MCSA. Thanks.
Thank you very much, Dr. Geddes. This was so exciting to hear about the different changes taking place in the cognitive and the emotional basis for treating with dementia people and the caregivers. Next, we have Dr. Tamara Carver, who is also a contributor to the report, and she will be speaking to us on the learning, design, and dementia education programs, learning, design, and experience matters. She's a director of the Office of the Technology and E-Learning for the Faculty of Medicine and Health Sciences at the Steinberg Center for Simulation and Interactive Learning. She's an associate professor at the Institute of Health Sciences Education and an associate member of the Department of Surgery. Professor Carver has a master's degree from Concordia University in the Department of Exercise Science, specializing in clinical exercise physiology, and a PhD from McGill's Faculty of Education in 2014. During her postdoctoral training, 2014 to 2017, in the Department of Family Medicine, she developed her first blended and online graduate courses, as well as the online scholarly activity program for clinical teachers and residents. This led to the creation of Family Medicine Innovations in Learning in the Department of Family Medicine in 2017, where she was assistant professor and education lead. Her talk today, as I mentioned, will be on dementia education programs, learning, design, and experience matters. Dr. Carver, the floor is yours.
Thank you very much. What an exciting day since 8 o'clock this morning. I just feel so privileged to be a part of this, honored to be asked to be an author, and this is just so exciting. My co-author is an incredible human being named Dr. Jerry Freed. He is the director of the Steinberg Center for Simulation and Interactive Learning, where I work. He's also the associate dean of Education, Technology, and Innovation for the Faculty of Medicine at McGill. And it was a pleasure for us to work together on this essay. So the three things I'm going to talk about today, one is the call to action. I want to highlight Claire's call to action that was in the World Report, as well as discuss the essay briefly, and I'm going to actually show it to you. And then the third one is to talk about the online curriculum for dementia education program that we're working. And then I have a surprise, something you've never done before. So that will be fun. So the first thing is the call to action. Claire said it so passionately this morning. She said it so passionately again today. And I so believe in this. And my role as an educator, creator, or technologist, or instructional designer is to look at those gaps and then create the curriculum or the courses to fill those gaps. And so that call to action of education for patients, for care partners, for medical students, for healthcare professionals and other professionals is something that I'm very passionate about. So in our essay that we wrote, and I'll share the screen, this was, as was introduced, dementia education program, learning, design, and experience matter. So I just want to highlight a few things in here that were really important. So this is really about creating more personalized and engaging learning, especially when you're doing community education as well as professional education. And so what we talked about here are the three principles that we use in everything that we create. So the first one is accessibility. So accessibility, it has to be at a place that is convenient for you and a time that is convenient for you. So as we know, as care partners, especially, it is not easy for us to go on site to have an education. So if it can be provided in a way that it comes to your home, such as we're doing now using Zoom, this is a necessary thing. So the accessibility. Also that it's clearly understood. So the language that is used is really important. The second one is experiential. So the idea with this is that you want to have learners emotionally connected to the material, that it resonates with learners. For some topics, that's more difficult. And for others, this is very easy because people are experiencing it themselves. And then the third one is usability. So the idea with usability is that it is understood even in terms of the technology that's used, but also the way we navigate it. So as we can understand, if I'm talking about innovation and I'm talking about different educational strategies, technology is going to be used. And for some learners, using technology does not come as naturally. So when we design any sort of educational course or curriculum, this is something that we take into account. So the usability. And then we went through, and you'll see Diane, who is the communications officer here at the Steinberg Center, has sent all these wonderful links in the chat. And so you'll see there that there's the link to the guide, and we're on page 404. And I highly recommend that you go through, just out of interest, when we design a curriculum, we follow what's called the ADDIE model. So right here. So that's analysis, design, development, implementation, and evaluation. So I won't go in great detail now, but just to understand that the analysis is those gaps that Claire identifies, so what those needs are. The design is then, how do we design it? How is it going to be delivered? The development is actually the filming of it. And you'll see that I'm sort of in a studio here, and you might see a little bit of that in a second. And then the actual implementation of it, and then evaluation. So I'm going to skip ahead to the third point, which was the online curriculum. And so the online curriculum for the dementia education program. So this is the website, which I think was also put in the link, but oh yes, it was. So Diane, yes, thank you. Put that in the link. So this is the website for the dementia education program that Claire, Serge, Dr. Gauthier, and Dr. Moret are the leaders of. And when you go onto that, I highly recommend you go to the Total e-learning. That link was also in there. So Total e-learning is an online curriculum that we are developing for family, friend, care partners of people living with dementia. And this is 10 online modules over 10 weeks. That will be for adult learners. And this will be launching in the new year in 2023. And throughout this, we are taking in all those principles that we talked about in the essay. So how do we make it accessible? How do we make it experiential? And how do we make it in terms of taking into usability, so that the buttons are maybe a little bit larger if we're looking at an older population that would be taking these modules. So I highly recommend that you take a look at this, and it will provide you with all of the information. As Diane mentioned, this was funded by the Public Health Agency of Canada, and all of the co-investigators are authors and leaders here of the dementia education program, and we're very, very excited about this. So one of the things that we do in terms of designing learning is this concept, and I'm sure some of you have heard it, blended learning or hybrid learning. And what that means is you have one component which is synchronous, that you do either, as we're doing now, in a video conference or in person. And here at the Simulation Center, prior to the pandemic, this would take place here, where there would be simulations with simulated actors or simulated patients who are playing the role of somebody who has dementia and a caregiver or care partner. So what we're doing with our online curriculum is we are taking the blended approach so that it can all go into the homes of the care partners, where there will be a synchronous session like we're doing now. And then that moment that was done here is going to be recorded and filmed. So we're filming scenarios using actors, and we're developing content that can be done at a convenient time for the learners. They can do it at a time when they have some free time. They could do it all at one time, or they could separate it over a period of time. So this is something we're very, very excited about. And as I mentioned, we're at the design stage of it and just about to develop it. And now to the final point, which is the surprise, is I'm actually going to take you on a tour. and this is probably never been done before. I've definitely not ever done this live in a public talk, but I'm going to show you the office. Give me 1 second. Okay, this will be fun. I'm going to wait till I see all of you. Okay, I see all of you and you can hear me? Yes, perfect. So this is the Office of Ed Tech. So this is here at McGill at the Steinberg Center. This is where we film everything with our subject matter experts. We have professional recording equipment, not a green screen, it's a gray screen, and I can explain that. And all of the equipment, it's just a beautiful place. And it happens to also be my desk. So that's where I work. And we're going to go to the simulated apartment. And if I lose you, I'll gain you in a second. So we're going to head down the hall. And we're going to go to, so here we are in the Steinberg Center. And we're going to walk into the simulated apartment. So I'm going to turn the light on. So this is a simulated apartment. Dr. Jelina knows this well. And this is where we have simulated patients, actors, play the scene of whatever scenario we want to demonstrate. And I hope I'm not making you nauseous. I'm trying to be as, okay, perfect. Here's a simulated bedroom. There we go. There's also a bathroom. I don't think you need to see that, but maybe you do. And right here, there's the control room. Like it's a one-way window. So on the other side, participants, learners would come here and witness the scene or scenario that was taking place that the actors were, or simulated patients were demonstrating. And then with the amazing Dr. Jelina, conversations are had about some of the reflections they had in that scenario. So I'm going to continue. I'll quickly show you the bathroom. Because, you know, it's a simulated bathroom and I know, there you go, very nice. Okay, and now we're going to see my team is on lunch. So I don't know if they're all here, but you're going to see the place where the entire works to develop the online curriculum. So this is the Office of Ed Tech, where everybody is working very, very hard on developing the online curriculum for the dementia education program. And they're all on lunch. So that is the Office of Ed Tech. That is the work that we're doing in creating innovative educational programs for the dementia education program. And thank you for your time. I hope you enjoy the tour.
Thank you very much, Dr. Carver. This was a treat to go through your simulated room. We've never seen such a thing before. Caitlin, what's happening? Okay. So again, I'm thanking you, Dr. Carver. Maybe you got off this line, but it was very exciting. Now we will have our next contributor to the report, Dr. Lisa Koski, who is a clinician scientist who combines research in cognitive neurosciences with practice and teaching as a clinical neuropsychologist. Her clinical expertise lies in the neuropsychological assessment and development of individualized recommendations for treating cognitive deficits and psychosocial distress within a mental health population, including neurodevelopmental disorders in adults. Dr. Koski's research aims to advance knowledge of how human brain systems control behavior using techniques that include non-invasive brain stimulation, structural and functional neuroimaging, and cognitive and behavioral assessment. This work includes the development and testing of novel rehabilitative interventions for neurocognitive disorders and associated mental health symptoms. Dr. Koski's talk will be about causes, effects, and outcome of anxiety in people living with Alzheimer's disease. Dr. Koski, please give us your presentation.
Thank you very much. Does everyone hear me okay?
Yes.
Yes. I have to say, Dr. Carver is going to be a hard act to follow with her dynamic presentation, but I'll jump right in. I'll share my screen for a moment. I think. One moment, please. Please. There we go. And here we are. And go. Is that good?
Yes, very good.
Thank you. Okay, so when I first got the invitation to write on this topic, I had, actually a few questions. So my first thought was, well, a lot of my work right now is as a neuropsychologist, and so I don't actually spend much of my time treating anxiety. And although I'm in the cognitive neuroscience field, it's not usually anxiety that's the focus of a lot of my research. So what can I say about it? But actually, on diving into the literature, which I found like a really fun journey, I found that this combination of backgrounds in clinical psychology and also in neuroscience gave me a good kind of well-rounded perspective that helped me make some sense of the topic. So I hope you'll enjoy as I share some of the questions I had and the answers that I discovered for those questions. So the first question I thought was important is, okay, anxiety. What do we mean by anxiety? Is this like ordinary anxiety? Like, I don't know about you, but I'm anxious when I don't remember something too. Or are we talking about something like diagnosable anxiety disorder? So part of what I ended up raising in my essay was, a definition of what do we mean when we talk about clinically significant anxiety. And by this, then, we would mean something where the amount of anxiety, or like the severity or frequency of anxiety, becomes overwhelming and starts to really impact on our day-to-day functioning. So, from my practice, I know that anxiety can interfere with cognitive performance, but also from my research, I found that a little bit of anxiety can be a good thing. Among some of the patients that we screened for anxiety and depression in the Geriatric Cognitive Disorders Clinic at McGill University Health Centre in Montreal, those with more anxious symptoms, we found surprisingly actually tended to score higher on the MoCA test. So I thought that was quite interesting. And we know that there's a bit of a curve. We know from years of psychology research that there is a curve in which a little bit of anxiety can lead to a kind of a peak cognitive performance in anyone, but that once it reaches a certain level, it does interfere with cognition. So I thought that was kind of interesting. So the second question I had was, so this is an essay about Alzheimer's, and I wonder, what does anxiety look like in people with Alzheimer's? First, are people with Alzheimer's disease more at risk of suffering from an anxiety disorder than those people who do not have that diagnosis? And once I dug into the research to write this piece, I was a little surprised to find this is not necessarily the case, except in the early stages. Maybe when the stress of wondering, do I actually have Alzheimer's? Don't I? If I do, how am I going to stand it? So finally, this kind of led me to consider a different kind of an explanation of some of these research findings that I observed, that people with more cognitive impairment, so those who had lower test scores, are maybe less likely to have the kind of insight that triggers anxiety about prognosis. So it's interesting because I'll speak then from personal anecdotal experience that it seems like sometimes anxiety and distress in the earlier stages after a diagnosis of Alzheimer's will decline with time across different stages, as loss of memory combined with limited insight can bring some relief from the anxiety and maybe usher in a calmer phase of the disease, although I imagine this is not always the case. So the next question I had was, how do we know that someone is anxious? When communication becomes difficult, our usual questionnaires for assessing anxiety in the general public may not be valid anymore. So the outward signs of anxiety we might observe clinically can tend to be non-specific. For example, like fidgeting with the hands or like wringing of the hands, which may actually be, psychomotor stereotypies type of thing, associated with neuropathic changes affecting motor control, or could be outward manifestations of suffering due to physical pain, in which case we know that we have to locate the source of that pain and be able to address these manifestations of anxiety. So it does remain really essential that we use are combined clinical observations with the the various behavioral expressions of anxiety in people in later stages of Alzheimer's, when they may have less ability to communicate their thinking, or if there's an anxious thought process behind what we're observing. So what exactly would cause anxiety in Alzheimer's? So there's many different putative causes and contributors that have been discussed in the literature that cover a wide range of different types, if you will. So some of these are neuropathologic explanations. Some researchers have found that plaques and tangles affecting the brain regions that are essential for filtering out irrelevant sensory information can lead to a sense of sensory overload and feelings of being out of control or overwhelmed. Alternatively, that some of this neuropathology is affecting regions that are very important for emotion regulation in the normal brain. And so these are kind of very disease-specific type neuropathological explanations for anxiety. Another class of explanations is more psychological. So here we're talking about fear about loss of functioning, loss of control, also uncertainty and fear of the unknown. And an interesting thing that's emerged from recent years of the decade of literature shows that anxiety actually can tend to decrease after a diagnosis of dementia. So this has really been interesting because, as was mentioned earlier, some people say, well, why should I bother, getting a diagnosis at all? Well, in fact, sometimes just knowing what's happening and maybe having an answer is enough to help the person start to then move on to coming to some terms with it, being able to set up care plans. But I think also we have to recognize the important impact of like a prise en charge, the kinds of access to resources and psychological support that's provided by healthcare workers, by family, and by the community once the diagnosis is made clear, which can then lead to a decrease in anxiety. So other explanations might be neurocognitive explanations. So the idea is that as cognitive decline happens in Alzheimer's, we see that this cognitive dysfunction makes everyday tasks more challenging. So that's something that might have been fairly straightforward, getting ready to go to a doctor's appointment on time, which used to be fairly simple, now become a lot more overwhelming, and that can lead to more everyday anxiety in people with Alzheimer's. So, but before I go to the next one, I wanted to say that it turns out that the reverse that although anxiety can impact cognitive performance in older adults, we know that the anxiety normalizes, cognitive test performance normalizes with effective treatment of the anxiety. So this kind of research suggests the importance of good anxiety management for people with dementia. Now, unfortunately, most of the medications that are used to treat anxiety have cognitive side effects, so you're in a bit of a catch-22. But fortunately, psychotherapy is a good possible alternative. Many people asked, can people with dementia actually benefit from talk therapy? And it seems that there is a literature on that supports the idea that some benefit can be obtained. So I'm just popping this up here with all citing Orget et al. In 2015. I don't want to draw attention to all the details of this, but just to point out in this forest plot that we see improvements in favoring treatment when we look at rating anxiety and dementia scale. Here we do see some improvements across at least 2 studies that have looked so far. And although self-reported anxiety does not seem to be significantly affected, the measures such as neuropsychiatric inventory, anxiety specific, does actually tend to improve as well. So these are kind of promising things. So I guess I'll just stop sharing here and just mention that I think it is promising, this notion that there are interventions that can be done for anxiety. It's known that modifications to the standard types of psychotherapy would be necessary in order to make these accessible to people with some cognitive issues. So if you're going to do cognitive behavior therapy, which usually has things like homework assignments, you would not be sending people off to do homework assignments on their own or have to write lengthy things. That it's important that these sessions be broken into smaller pieces and that the ideas be introduced slowly, and not having a heavy demand on attention. But that in fact, with these kinds of modifications, we do have effective psychotherapeutic interventions for anxiety in people with dementia. And that's about all I have to say today. Thank you so much for your attention, but also very much for this opportunity to contribute to this report. I'm amazed at its length and at the breadth of the content covered, and I'm excited to get reading the rest of it. Thank you very much.
So thank you very much, Dr. Koski, for opening up a new avenue of trajectory for the persons suffering from dementia. And I mean, this was something different to how to manage the anxiety, because we see that so often in clinical practice. So thank you again very much for this opportunity for us to hear your presentation. We now come to a more concrete part of our presentation, the advanced care planning in dementia, which is affecting many of us as well as our patients and as well as our caregivers. So Dr. Catherine Ferrier will be presenting that, and she's a family physician and holds a certificate of special competence in care of the elderly from the College of Family Physicians of Canada. She works in the Division of Geriatric Medicine of McGill University Health Centre, where her focus is on cognitive disorders and assessment of decision-making capacity, which is very important. She's assistant professor in the Department of Family Medicine in McGill University, and she will talk to us about her contribution to the second Alzheimer report. Dr. Catherine, this is yours.
Thank you so much, Dr. Destor. It's a pleasure to be here. As you learned, I'm a family doctor, and I fell into geriatrics in 1984, and I've been there ever since. There were hardly any geriatricians in those days, and so I learned it on the job. And I work in the geriatric clinic at the Montreal General, which has become more and more focused on dementia over the years as other parts of geriatrics became more, I guess, accessible for family doctors. And I've also been involved for a few years in advocacy work for better end-of-life care. So advanced care planning sort of followed directly from that. So the idea of planning ahead for serious illness makes perfect sense, but it's not as simple as it might seem. So I've had advanced care planning discussions with patients, their families, members of my family. I've given seminars on it. I've taught medical students about it. And the more I try to study it and apply it, the more I see that it will never be simple and straightforward. Life is too complex. Human nature is too complex. There are too many unknowns in our medical and personal future to be able to decide everything in advance. So when I was asked to write the essay for this wonderful project, the World Alzheimer Review, it was a great opportunity to review the literature on this topic. And what it shows is a big divide between what the public and many clinicians think needs to be done on one hand, and what studies have found and what experts in end-of-life care are saying on the other. I was asked in preparation for this talk to touch on my personal journey in the writing and research process, and I can say above all that it took many, many hours, but it gave me many new insights and confirmed much of what I learned from my clinical and personal experience on this topic. So here's a little synopsis of what I've learned over the years and in the process of writing this paper about advanced care planning. As you know, it's a reflection and communication process with the goal of ensuring goal concordant care near the end of life for people who lack decisional capacity. It's grounded in the principle of autonomy, which is prominent in Western societies, although that can sometimes be detrimental to other ethical principles like beneficence and so on. And in many non-Western cultures, autonomy or autonomous individual decision-making is a foreign concept. For example, in Asia, there's more of a focus on duties, obligations, families making the decisions together rather than the individual, and the well-being of the whole family being considered when making a medical decision. As I'm sure you're aware, advanced care planning developed in response to the growth of technological medicine in the 20th century, which, despite saving many lives, led to the dilemma of people being rescued from acute events only to remain gravely ill and comatose, dependent on that care to stay alive, but unable to decide whether to continue it or not. It makes intuitive sense to apply it also to the population we're interested in, to apply it to people with possible dementia or incipient dementia, because decisions will probably be needed for several years after decision-making capacity is lost, and regarding all aspects of life, not just medical care. So the early attempts to address this involved creation of the Living Well or Advanced Directive, which I'm sure you've heard of. So documents, the early documents, people would list which medical interventions they would want or would not want if they could not express their wishes. And this, it became clear quite quickly that this was a very limited approach and it was not sufficient. As early as 2004, there was an article published called Enough, the Failure of the Living Will. We've been trying it, we've been promoting it, it's all over the place, but people just don't get it and they don't apply well. So more recent programs emphasize a dynamic process of dialogue, supporting patients and their families to formulate goals of care as they move along the trajectory of a progressive illness. So they combine reflection on healthcare goals, healthcare choices, with naming and communicating with a surrogate decision maker who becomes a key person in this process. But even there, research is still far from proving clear benefit. In fact, a review in 2020 of 69 studies found no effective advanced care planning on goal concordant care or patient quality of life, which are obviously the outcomes of interest, despite success in process and action outcomes like increased knowledge and completion of directives. As I'm sure you can all appreciate, this is not like studying the effect of an antihypertensive medication where you've got one clear, simple intervention versus an outcome. These are very broad, many are different from each other and so on and so forth, but the research so far does not show clear benefit. So why this discrepancy? So a recent article by Morrison et al. In 2021 called What's Wrong with Advanced Care Planning? And I'll read you, I'm afraid it's a slightly long quote, but I think it's worth reading. Treatment choices near the end of life are not simple, consistent, logical, linear, or predictable, but are complex, uncertain, emotionally laden, and fluid. Patients' preferences are rarely static and are influenced by age, physical and cognitive function, culture, family preferences, clinician advice, financial resources, and perceived caregiver burden. Surrogates find it difficult to extrapolate treatment decisions in the present from hypothetical discussions with patients in the past. Prior directives are often absent, poorly documented, and either so prescriptive or so vague that they can't promote informed goal concordant care. So that's the end of that quote. So advanced care planning relies on what has been called precedent autonomy, which is the notion that an autonomous decision now is perfectly applicable to an unknown future situation. And this is contradictory to informed consent, which requires provision of information that can't be known in advance, like the diagnosis at the time, the treatments that are applicable, their chances of success and harm in the present situation, alternatives in the present situation. We cannot know all that in advance. And there's also increasing evidence that people predict poorly their quality of life in hypothetical situations. So this has been attributed to what are called cognitive biases, such as projection bias, so projecting our present preferences onto the future, focalism, focusing on what gets worse, not what remains positive in a life situation, immune neglect, which is underestimating your own adaptive capacity. So that's why we often observe a change in preferences for care as people progress through advancing illness and adapt to it and accept it. So what advice should we offer based on that to people who may develop dementia or are already in the early stages. We can't just say don't plan. Of course, we have to plan. The person's advancing in age, their disease is progressing, they're expected to lose decision-making capacity. We have to plan for not only medical care, but housing, personal care, financial management. So one key point, especially for medical decisions, is the choice of a surrogate decision maker. Not everybody might have someone that could play that role, but most people do. So choose and prepare a surrogate decision maker who first have to know the patient really well, know the patient's values, know their hopes and fears, all of those things that will need to be taken account, perhaps when the patient is no longer able to express them, but that the surrogate will know. And then support and educate the surrogate to participate with confidence in medical decision-making based on their knowledge of that person to help identify goals of care in the true present interest, as opposed to guessing what they meant by something they said or wrote in the past. All of that taking into account who that person is, their current diagnoses, their degree of frailty, which increases as dementia progresses. And this approach is much more compatible also with many non-Western cultures, which don't exist only in their countries of origin, but in Canada, where we're so multicultural, and where family members are much more naturally involved in decision-making for an incapable parent or other relatives. So the surrogate. Then we have to teach health professionals how to talk to patients and how to talk to surrogates, to how to discuss serious illness with patients and surrogates. So it gets back to education that's been mentioned several times today. So what information they need to provide and in what way. So if there's a crossroads, a decision that needs to be made about a medical treatment, about a residential option, it's not simple to provide that information in a way that people understand and can work with. And one expert wrote that, like learning a surgical procedure, it requires specialized knowledge and skills, training with feedback from experts and ongoing practice. So the medical trainees, the doctors, the other health professionals have to keep practicing to get good at doing this. And tools have been developed to teach those skills. One is called the Conversation Project, very interesting. Another is called Vital Talk. There are many others. So those need to be developed further and applied further and used in teaching health professional trainees. So we have to learn from all this without giving into the misleading simplicity of advanced directives, which is the title of another article written not long ago. So help people to plan ahead, not by writing hard and fast recipes for the future, but by involving family decision makers who know the person well, are able to make decisions based on their knowledge of that person, as well as on clear communication from the healthcare providers in each situation as it arises. That's all. Thank you.
Thank you very much, Dr. Ferrier. This was very important for all of us to know how to plan, advanced plan for our loved ones, as well as for ourselves if we need it in the future. So thank you again once more. Now we have Dr. Laura Robbs, who is a certified genetic counselor at McGill Research Centre for Studies in Aging, where she contacts families to assess the risk of hereditary types of dementia, informs them of implications, and guides them towards appropriate medical follow-up. She's also involved in recruiting people from identified families into the Registry on Early Onset Alzheimer's Disease in Canada and into the Dominantly Inherited Alzheimer Network, DIAN. A talk will be on early onset Alzheimer's disease issues for families. And we are all very anxious to know if we are personally at risk of developing the disease. So Dr. Laura Robbs is going to tell us if we are or if we are not. Laura, please go ahead.
Hello, everybody, and welcome. Thanks for joining us today. It's been my honor to be part of this amazing report. I'll be talking about issues for families in early onset Alzheimer's disease. So to put this in context, there are 3 defined types of Alzheimer's disease: sporadic Alzheimer's disease, late onset familial Alzheimer's disease, and early onset Alzheimer's disease. And questions that come up, as Dr. Dastor just mentioned, is from families is, why is this happening to my relative? And am I at risk for Alzheimer's disease myself? Sporadic Alzheimer's disease represents the great majority of cases, in which case there is no clear family history of Alzheimer's. It's mostly late onset Alzheimer's disease, but sometimes it can be early onset Alzheimer's disease where symptoms occur prior to age 65. The lifetime risk for anyone in the general population for sporadic Alzheimer's disease is about 10 to 12% in a 75 to 80 year lifespan. Late onset Alzheimer's disease is characterized by more than one family member and possibly more than one generation with Alzheimer's disease over age 65. This represents 15 to 25% of all cases, and first-degree relatives meaning siblings, children, have a slightly increased risk of having Alzheimer's disease themselves, 15 to 39%, which represents about a 2 to 4-fold risk compared to the population. In talking about early onset Alzheimer's disease, this is quite a rare condition. It only represents about 1 to 5% of all cases. And this is characterized by Alzheimer's in at least 3 related family members in 2 or more generations, all under the age of 65 years. So first-degree relatives in this particular condition have quite a high risk of developing Alzheimer's, up to a 50% lifetime risk of developing Alzheimer's themselves. Clear genetic causes are found in about 40 to 80% of these families. Genetic causes meaning a specific genetic mutation in one of these 3 genes mentioned here. So, what kind of information can genetic testing provide in these families? There's 2 types of testing one can do: testing for an affected person in the family and testing for an unaffected family member, often called predictive or pre-symptomatic testing. So genetic testing for a person with symptomatic Alzheimer's disease can be useful in diagnosis, providing an explanation for the condition, and the information can be valuable for affected people and for their family members. Even if testing is not desired, the consideration of DNA banking before a person actually passes away might be valuable to consider in order to leave options open in the future for the family to know more. Genetic testing for the affected person might be useful in considering specific treatments or clinical trials. If a clearly causal mutation, genetic mutation, is identified in this symptomatic person, only then can genetic testing be considered for relatives. If, on the other hand, the test does not show a causal mutation, we call that a negative result. This does not completely eliminate a genetic cause. The result is considered inconclusive because the current testing may not have detected a mutation in a known gene, or perhaps the person has a mutation in a gene for which currently there is no test. However, a negative test does reduce the probability of a hereditary form of early onset Alzheimer's. So when looking at predictive testing for family members, as mentioned in the previous slides, testing of the symptomatic person precedes the testing of asymptomatic family members, because in order to know if family members are at risk, specific mutation must have been identified in the family. Fortunately, this makes results relatively informative for the unaffected relative. So the results, if a result shows the presence of the family mutation, this will confirm that the person is at high risk of developing Alzheimer's themselves, and may clarify risks for other family members, such as their own children or grandchildren. If a test shows that the family member does not have the genetic mutation, this indicates that this family member is not at an increased risk of Alzheimer's. So there are numerous issues involved in consideration of genetic testing. We always talk about informed consent for testing. Testing for an affected person with cognitive decline can present numerous ethical challenges due to questions about their decision-making capacity and their ability to comprehend the genetic test results. For family members, knowledge regarding the test and the meaning of the results is essential so that they can reflect on the options and make their decisions. Many studies evaluating psychosocial impact of predictive testing have shown that knowledge about the presence or absence of genetic factors can stimulate feelings of distress, guilt, anger, relief, empowerment, as well as changes how individuals feel about themselves and how they believe others may be judging them, and can alter their perception of the future. The value of privacy of one member of the family might come in direct conflict with a healthcare professional's duty to inform family members of their own risks. This is where the importance of intrafamilial communication comes in, and obviously this differs from family to family. Insurance is an issue often brought up And while genetic discriminations laws do exist in some areas, including Canada, this is clearly not worldwide. And finally, how confidential are your genetic results and who might have access to them? Should your employer know about these results? Should the government know? And again, I don't have answers for all these types of questions. These are just a list of personal motivations for genetic testing. I'm not going to go through it all in the essence of time, but sometimes people are considering it because there's a presence of symptoms, they have memory issues already, and they want to know. And sometimes it would help them to reduce worry or help with general planning for the future. Conversely, there are also reasons for declining testing, the emotional impact of a genetic test on yourself or your family members. Some people feel they can emotionally cope with their increased risk without testing. And sometimes the timing. Sometimes people prefer to postpone testing till after they've done childbearing or their children are grown. So it's a very personal decision. As I said, and the most important thing is to obtain and understand the information regarding the condition and the test. And then you're able to give informed consent if you'd like to proceed with the test. Because genetic evaluation in families with early onset familial Alzheimer's brings up many questions for both individuals and their healthcare providers. Families with this condition should be encouraged to seek out information and obtain referrals to specialized centers when appropriate. And what I really want to underline is that the importance for any person to understand the facts and the issues surrounding early onset familial Alzheimer's in order to be empowered to make the medical and lifestyle choices, which are the right ones for themselves. Thank you.
Thank you very much, Laura. Now we come almost to the end of our program, and Dr. Saskia Sivasanathan, who is the Chief Science and Knowledge Translation Officer at the Alzheimer's Society of Canada, who oversees the research program, a dementia research priority setting leader, is going to talk. She's a neuroscientist herself, is going to talk to us on navigating the path towards for dementia care in Canada. Dr. Sivanathan has served as a senior strategy and policy advisor consulting for the WHO, World Health Organization, on its global dementia strategy. She co-drafted the WHO's Global Action Plan on Public Health Response to Dementia. And in 2020, she was appointed by the Federal Ministry of Health, Canada, to the Ministerial Advisory Board on Dementia. Today, she will inform us on navigating the path towards the dementia in Canada. Dr. Sivanathan.
Thank you very much for having me, and it's a pleasure to be able to contribute to this wonderful report. In the interest of time, I'm going to try and keep my slides to a minimal and really focus in on just some of the key pieces around navigating the path forward. In fact, the Alzheimer's Society of Canada produced a report just a week before this report came out today, but the two align very nicely because, of course, the World Alzheimer's Report takes a global view and perspective, which is very close to my heart, on dementia. And what I'll try to do is summarize and bring things a little closer to home in terms of what things look like in Canada. Can everyone see my slides right now? Just going to check.
Yes.
Perfect. Thank you. All right. And it appears to be there. That better?
Yes.
Thank you. Thanks, Caitlin. So very briefly, when we're looking at the Canadian landscape, we're seeing that there are just over 500,000 Canadians living with dementia right now, and that number is going to grow significantly over time. We saw that same sort of rise in the global report. In Canada, by 2030, there's predictions for almost 1 million people living with dementia, and by 2050, that's 1.7 million people living with this disease. And of course, this is not an individual journey. And this was exactly the point that Claire highlighted as well as many of the other contributors to the report. Care partners, and they're often called informal caregivers, though there's absolutely nothing informal about the kind of work that they're doing, are crucial to ensuring that that journey is one in which the person's needs are being met and that they're receiving quality care. In Canada, we are estimating, and this is a very conservative estimate, of about 350,000 care partners who provide on average about 26 hours of care a week. But if you translate that, that's about 470 million hours a year, all unpaid, all voluntary, and all of which is quite complex. That translates into 235,000 full-time jobs currently being performed by people who are, quite frankly, trying to hold down full-time jobs, or who have retired and or are managing their own health concerns and issues, who have no real systematic support, no infrastructure support that's recognized by the healthcare system or really by physicians who are providing care. And what does this cost? About $7.3 billion. That's right now. That number will almost triple by 2050. So the urgency of the call to action that Claire, Serge, Pedro, and many of the others have been highlighting is how important it is that we provide better infrastructure, both for people living with dementia, but for their care partners as well. And that starts with education. One of the things that the report that we produced also looked at was, is there hope? Because there is hope. A lot of the research has progressed quite a bit. We've heard about all of the wonderful sorts of research in terms of treatment, understanding dementia better, but there's also the power of dementia reduction and risk reduction that collectively can reduce the overall number of cases of dementia. And one of the things our report looked at was if we were able to reduce the onset of dementia by just 1 year, or 1 year, and it could be potentially a range of treatment options. It could be just implementing different lifestyle changes to reduce your risk overall. We could delay over almost 500,000 cases of dementia. That's not a small number. So there really is quite a big investment that needs to be made in risk reduction as well. And again, education about what risk reduction means, what those lifestyle changes are, and having the healthcare system and doctors and physicians support it. I won't go into this in detail at all, but it basically summarizes the evidence around some of the key risk factors that are linked to dementia. There are those that are modifiable, and then there's those that are non-modifiable. The ones that are non-modifiable are risk factors that you have no control over now or couldn't really control, really. For example, lack of education in early childhood. But there is a lot that you can do and that you have control over. That's what the modifiable risk factors are. And the World Alzheimer's report highlights these same risk factors as well. And some of them are very specific to dementia that people aren't aware of. Many are aware of sort of exercise and, eating healthy, reducing alcohol intake, all of those. But there are others, such as hearing loss, for example, and treating hearing loss early, which is also linked to reducing your overall risk of dementia. So let me come to actually one of the questions that I saw in the chat, and which I think would tie together a lot of the pieces around Canada's strategy. There was a dementia strategy for Canada that was released in 2019. And it was welcomed with a lot of excitement because it meant that dementia was finally being recognized. And what that strategy really focused on was a public health approach to dementia. It meant focusing on risk, on education, and many of the recommendations that have been highlighted in the World Alzheimer's report were also raised in the dementia strategy. However, the strategy has not been fully costed out, and it also has not been fully implemented. And this is where a lot of the weaknesses lie as part of our healthcare system with a federal and provincial approach where there are gaps in the overall system. So what does this mean for us in terms of the opportunities for a path forward? So I'm going to stop sharing my screen and speak to some of it. Here we go. I can now see your faces. Well, one of them is It's been multiple years. It's actually now been 3 years since the strategy was released. What is the actual cost of being able to implement the recommendations that are made in that strategy? And how will those get implemented? What are the KPIs? How do you measure that you are reaching successfully the implementation measures? This is part of the call to action for the government. The other is investing in dementia research. Canada notoriously underfunds research in dementia. When you look at some of the other partners who fund research in the UK and the US, Canada is well below our funding goals for dementia research. And it's going to be one of the only areas in which the kinds of research that you just heard can progress, but it can't progress without better funding. And then, of course, there's education. We talked about that quite a bit, but it needs to be an approach in which all family physicians have the sort of education that supports them, not just in making a diagnosis, but as is highlighted in the World Alzheimer's report, in post-diagnostic support. There's a whole lifetime in many ways after a diagnosis of dementia. And the message should not be to go home and get your affairs in order. And that's very much what we hear at the Alzheimer's Society. When clients come to us, people living with dementia and caregivers speak to us through our info line, they're telling us all they heard was, you've got dementia. Okay, here's a diagnosis. Go get your affairs in order, make sure your will is set up, and that's about it. There is no pathway of care. There's no appropriate supports. There's no education to help them plot through that journey. And this is an area that we really need to invest in much more. I'll stop there because I know we are very much over time. I look forward to hearing Pedro. Thank you, everyone.
Thank you very much, Dr. Saskia. You said everything what we used to say 20 years ago to our patients. You know, we have come a long way, and I thank the Alzheimer's Societies all over the world for that. You know. And finally, we have our last speaker, who is Dr. Pedro Rosaneto, who needs no introduction, but I will introduce him just the same. And he will give us experience as the author of the report and give us his closing remarks as well. Dr. Pedro is a professor in the departments of neurology and neurosurgery and psychiatry at McGill University, and director of the McGill University Research Centre for Studies in Aging, and was recently named adjunct professor of the Department of Biomedical Sciences and Engineering at Guangzhou Institute of Science and Technology in China. He's a clinical neurologist with expertise in the quantification of dementia pathophysiology and preclinical diagnosis of Alzheimer's disease using biomarkers. He has been recognized by the Fonds de la Recherche en Santé de Québec as a senior scholar and has a leadership role in the Team 2 Canadian Institutes of Health Research, CHRR and CCNA. Dr. Pedro, please give us your closing remarks.
Thank you so much for the kind introduction, Dolly. Do you have, can you see my slide?
Yes.
Okay.
Yeah.
So first of all, I'd like to thank the speakers and the attendants. Thank you, Dolly. Thank you, Silvana and Caitlin, for organizing this dissemination activity. Education is one of our core values, and I'm delighted to provide some closing remarks. So this is, I'm showing here the 2021 and 2022 reports that are contributions from the McGill Dementia Education Program, the McGill Center for Studies in Aging, the Geriatric Division at McGill, and demonstrate the breadth and the scope of aging research in our institution. So last year, the report focuses on the diagnostic and therapy, and this year it focuses on the post-diagnostic care. All of the recommendations from both reports aim to fulfill important needs, provide health care, support, and dignity for people living with dementia and their care partners. Among many other aspects already discussed, the report highlights personalized care. Personalized care and support, personalized support plan should consider diagnosis of the underlying cause of the dementia, management of medical aspects, including various comorbidities, and this care should respect social, geographical, and cultural circumstances. So education is crucial to people living with dementia and the care partners, as well as to medical care providers, and should start very, very early in their education process. This education empowers and is the key element to scale patient needs worldwide and increase the accessibility to post-dementia care to everyone. So regarding to the authors, I'd like to make some extra considerations. So I think we have to acknowledge, apart from Dr. Gauthier and Claire, that they were very well acknowledged, Steen Servais. So Steen, he is responsible for all the surveys and the complex analytic procedures for the surveys. José Moraes, who contributed to many aspects of this report. We have also support from the Chloé Benoit from ADI, Wendy Weiner, that contributed for the final edition of this report, and Carol Servais, who was our assistant editor and helped us on this entire journey. And I'd like to also to highlight that on both reports, you can easily recognize the vision and the guidance from Professor Serge Gauthier, who has inspired various generations of clinicians and clinician scientists and healthcare professionals willing to improve the life of people living with dementia. Thank you so much.
Thank you.
Rosanetta. Before we go, I just wanted to highlight a few of our community groups. So Marie-Christine, if you want to say a few words about Alzheimer's Society Montreal.
Yes, thank you. Thank you very much. I'll be quick. So the Alzheimer's Society of Montreal was founded more than 40 years ago, and our mission is to alleviate the social and personal consequences of Alzheimer's disease and related disorder through the development and delivery of leading-edge intervention, care, and support services in Montreal. On this day, talking a lot about post-diagnostic support, I want to thank the McGill Research Studies for Aging for this opportunity to share. On this slide, you can see some of our areas of action and how we help people living with dementia and their care partners. Our services are based on the person-centered approach to care, very well presented today by Dr. Guedes. I hope I had the name right. And our services vary from individual psychosocial support for carers, also for people living with dementia, or the one that just received a diagnosis. We have art therapy support groups, therapeutic leisure activities, cultural activities, respite and stimulation programs that are at home, also in home, and in activity centers. And on that matter, we are inaugurating today our permanent activity center in our main office that can welcome people living with dementia until late stage of Alzheimer's disease. So our services are accessible on one floor number that we saw on the screen, and you can call us at any time. So thank you for this opportunity and also for this tremendous work from McGill's Studies on Aging. Thank you.
Perfect. Thank you so much. And we also have Megan Williams, who's joining us from AGI. If you want to say a few words about AGI, that would be fantastic, Megan.
Thank you, everyone, for all the wonderful work that you have contributed today. It's amazing and wonderful to see so many brilliant resources and research studies being done. And AGI is really proud to be a part of the community of dementia care. So just very quickly, AGI, we are a nonprofit organization in Côte Saint-Luc in Montreal. And our main mission is to provide support services to families and people living with dementia, as well as therapeutic programs for individuals with not only Alzheimer's disease, but other dementias. We focus on support and training opportunities for professional caregivers, and especially awareness to the community. So just very quickly, our demographics is primarily Anglophone, based on where we're situated in Montreal. And we provide the services for people at all stages of the disease and all types of dementias. So there's no need to have a formal diagnosis, but we help guide families to the right steps and how to access medical care and to get that diagnosis, because as we've heard, advanced care planning is so important, and being there, walking the family through the journey is pivotal. So right now we have in-person services in Côte Saint-Luc, as well as a hybrid approach on Zoom and also on the telephone. For the caregivers, we have a hotline, individual and family counseling, as well as different types of support groups, because we find it essential that people are categorized based on where they are in the course of the disease. We have support groups for adult children, spouses, as well as some young onset we've had in the past. And also we have a support group that's just starting for people with a diagnosis who want to talk about the disease. So it's really important. We also have monthly webinars, interactive courses, and different programs for caregivers. For the person with the disease, we offer individual counseling. We have an activity center online and in person, as well as different social groups and music therapy twice a week that happen in late afternoon for the sundowning. So pretty much if anyone is interested in our organization, we often refer people to other organizations because we know that one person can't do it alone. They just need to give us a call, and we will try to do our best to see what's fit for the family, because it's such a difficult journey, and we are here with them from the beginning of the diagnosis, even in bereavement. So thank you very much.
Perfect. Thank you so much. You guys, everyone was absolutely fantastic.
I thank you extremely very much for all the work you guys have done in producing this report and for presenting today and giving us an insight into what is happening in the Alzheimer world and helping the caregivers as well as the patients to navigate their lives as best as they can. Thank you so much, and God bless you.